My name is Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. I would like to discuss the Oncotype DX assay and consider who should get one in the management of ER-positive, lymph node negative early stage breast cancer. The Oncotype DX is a 21 gene recurrence score assay. It's a measurement of the messenger RNA for 16 cancer-related genes and 5 reference housekeeping control genes from 3 different studies of primary breast cancer. Among the genes of interest on the recurrence score assay are proliferation-associated genes, for example, Ki67, estrogen receptor-dependent genes, like the estrogen receptor itself, the progesterone receptor, invasion genes like cathepsin, HER2-related genes, indeed HER2 itself, and GRAB7, the gene which resides next door to HER2 on the long arm of chromosome 17, and is almost always co-amplified along with HER2, is one of the genes as well. The reference genes are beta-actin, GAPDH, etc. Now, there's a mathematical algorithm that assigns weighting factors to each of these groups of genes: proliferation, estrogen, invasion, HER2, etc. And based on this mathematical algorithm, you can assign a quantitative recurrence score. This score can be further broken down into low-risk patients that have an exceptional prognosis with endocrine therapy alone without any chemo, an intermediate risk score that have a little bit more guarded prognosis, and then a high-risk recurrence score that's associated with poor prognosis and has been shown to benefit from chemotherapy. The NSABP B20 study was an important investigation that allowed interrogation of the predictive value of the recurrence score in treating ER-positive lymph node negative patients. The low-risk recurrence score patients had no benefit in a randomized trial of tamoxifen with or without chemotherapy in a post-hoc analysis of the recurrence score assay, whereas the high-risk patients clearly benefited from the addition of chemotherapy in the same randomized trial. And the intermediate risk score was not statistically significant in this trial, although there were very few events in that trial, and that was the reason for the more up-to-date TAILOR-X trial, which I'll discuss shortly. Importantly, there are some patients that are clinically defined as being high risk, but when you measure their recurrence score, you may find that on a molecular level, they are low risk and can safely avoid all the toxicity and expense of chemotherapy. So that's the major contribution of this assay, in my estimation, is identification of a low-risk group of patients who don't benefit from chemotherapy and can save them the side effects, toxicities, expense, etc. of chemotherapy, including late side effects. All that can be safely avoided now with the introduction of these multi-gene assays, and that has been a huge impact on patient management. The TAILOR-X clinical trial was an important update to the Oncotype DX story. These were patients who were randomized to receive either chemotherapy along with endocrine therapy or endocrine therapy alone if they had intermediate risk recurrence scores. There were other patients in this 10,000 plus patient study that had a low recurrence score, and all those patients were assigned automatically to endocrine therapy. And there are publications recently in the New England Journal of Medicine showing that those patients did exceptionally well without any chemotherapy, and endocrine therapy alone is appropriate for these low-risk recurrence score patients. High-risk recurrence score patients were assigned to endocrine therapy plus chemotherapy as per the standard of care. So it's really this intermediate range with recurrence scores between 11 and 25. And there were 6,711 of these patients that were randomized to chemo plus endocrine therapy or endocrine therapy alone. And that's the most important point of this TAILOR-X clinical trial. Now, if you look at the top line data, the Kaplan-Meier plots for chemo and endocrine therapy versus endocrine therapy alone are superimposable for both invasive disease-free survival and distant relapse-free interval. There was no difference in the intent to treat population. However, there is one caveat to this interpretation of TAILOR-X data that's really critical, and that is for younger patients, let's say under than or equal to about age 50, The patients with recurrent scores that were on the higher end of the intermediate range appeared to derive an important benefit from chemo, and also patients who were 50 or younger who had high clinical risk features based on the tumor size and the tumor grade also appeared to benefit in a meaningful way from chemotherapy. So there are some subsets with this intermediate range, particularly at or below age 50, where it's important to think about chemotherapy, even though the lion's share of these intermediate recurrent score patients can now safely avoid adjuvant chemotherapy. So that's an important advance to our clinical practice, knowing that for almost all the postmenopausal older patients, older than 50, with intermediate recurrent scores can safely avoid chemotherapy. And that's a huge number of patients now that can be added to the list of patients who can avoid the side effects and toxicity as well as expensive chemotherapy. In summary, clinical risk provides additional prognostic information to the recurrent score for distant recurrence. Clinical risk alone, however, did not provide predictive information for chemo benefit. Absolute chemo benefit was greatest if patients were premenopausal and aged about 45 to 50 with recurrent scores of about 16 to 25, suggests that there may be an absolute chemo benefit due to an endocrine effect by suppressing the ovaries from the chemotherapy. And this integrated risk provides greater prognostic information and precision and may have clinical utility and is superior to clinical or genomic features used individually. Finally, the TAILORx data eliminates the need for another huge population of patients that can safely avoid chemo. It is to note that the Oncotype DX has now been integrated into the AJCC staging system for breast cancer based upon its precision and reproducibility and the strength of the pioneering studies interrogating this important marker in ER-positive early stage breast cancer. Thank you.